for is probably beneficial for most babies. So any thoughts from the audience? I have not put in a polling question, but I just wanted to know what you feel. Feel free to chime in or put it in the chat box. So that says true. So he does believe that pharmacological treatment of moderate or large PDA is probably beneficial. And there are more people from the audience, Amit, Piyush, who all think that there is a role for pharmacological treatment. So let me take a deep dive into it and let's tease this out further. So the learning objectives of my talk is to appraise the evidence till date with regards to PDA treatment in preterm neonates and to evaluate key issues in PDA management and provide suitable solutions that will help establish causality between PDA and adverse outcomes, and to evaluate newer approaches for PDA assessment and management. And I'll share some of my work and my group's work, which is in publication or has been published recently. And lastly, to have a primer on conservative management, because there's a lot of noise that this is the new treatment in vogue, and which babies will truly benefit from it and which babies might have some harmful effect due to this approach, and we'll try to delve into it further. So there are three pathologies in newborn medicine which have flummoxed and perplexed us as neonatologists in the past few decades. It's BPD, necrotizing enterocolitis, and lastly PDA. Such an innocuous serpentine-looking structure, which so far 4 or 5 decades have passed, almost 80 RCTs and counting. There's still no consensus amongst neonatologists across the globe, and it is still a very contentious issue. And as you can see, multiple surveys done in North America, Canada, Europe, the jury is divided. There is no consensus amongst cardiologists and neonatologists, and even among neonatologists, there are units where there is no ductal treatment and everything is watchful waiting, and there are units where it's aggressive treatment, and there are some units who have taken the middle ground. And all our sentiments are summarized in this key statement by American Academy of Pediatrics in 2016, which essentially said, despite a large body of basic science and clinical research and clinical experience with thousands of infants over nearly 6 decades, there is still uncertainty and controversy with regards to A, significance, B, how should we evaluate it, C, what is the ideal management strategy, and resulting in substantial heterogeneity in clinical practice. And as you can see, sorry, this is a network plot which Dr. Shouvik Mitra from Halifax had published in JAMA. And as you can see, all these nodes are for one agent, and there are so many comparisons between various therapeutic agents. Low dose standard dose ibuprofen, high dose ibuprofen, continuous indomethacin, intermittent indomethacin, and Tylenol. And it's an absolute chaos, something like parliaments across the globe. So why is PDA considered a threat in preterm babies? Because physiologically, if you go to see, it does make sense that it can cause a lot of problems. A PDA can shunt blood left to right, leading to pulmonary overcirculation. And this problem is more pronounced in preterm babies due to reasons we know. It can lead to pulmonary edema, prolonged ventilation, and may be associated with BPD. I'll come to why we have failed to show any association. In addition, because of the increased pulmonary blood flow, and if you have a moderate to high volume shunt, then you might have some protein leakage from the alveoli, which might inhibit surfactant and decrease lung compliance and worsen the pre-existing lung disease. On the other hand, since most of the blood is getting diverted towards the pulmonary circuit, and there is some amount of steal or retrograde flow, uh, there is more and more evidence that there is evidence of systemic hypoperfusion, which we see in echo when we traverse the Doppler flow in celiac arteries, superior mesenteric arteries, middle cerebral arteries. And so you can have end organ perfusion. And again, there is a possible association between a PDA, neck, IVH, severe IVH, and PVL. But the relationship between PDA and outcomes, between all these bad outcomes, common neonatal morbidities, is confounded by so many confounders, ranging from sepsis, maternal infection, low platelets, prematurity. We know smaller and sicker patients where hypoxemia and inflammation are the key drivers, those patients tend to have PDAs for longer. So this complex association is further confounded by all these confounders. And that's the reason most of the retrospective studies have not been shown to establish causality for PDA for bad outcomes. And to worsen this furthermore in the same area, we don't have a standardized definition of hemodynamic significance. We don't have a standardized which are the at-risk infants who may have more problems compared to the rest of the preterm cohort. And lastly, we don't have standardized echo assessment parameters. Most of the trials have looked into simplistic echo criteria, not taking into account clinical criteria or other measures. So this is the evidence till date. And as you can see, this was a meta-analysis done by Dr. William Bennett, which was published in Journal of Perinatology. And as you can see, apart from ductal patency and severe IVH, for the 55 to 60 trials done till date, there is no benefit seen for mortality or for common morbidities, which we commonly encounter in our practice. So naysayers would say that, oh, let's look at the data more finely and not club the trials from 1970s to 2020. So even if you break it down to treatment being less than 50% in the control arm, or if you are only looking at extremely low gestational less than 29 weeks and age at treatment less than 5 days, apart from reduction in ductal patency and reduction of severe IVH, there's no real benefit. And as you can see, just to draw your attention, babies less than 29 weeks have been underrepresented in trials done so till date. There are just some handful of trials amongst the 80 trials so far, ranging from 5 to 12. So like Dr. Fauci, we are also perplexed and confused that why RCTs have not shown any benefit of PDA treatment in spite of body of evidence over 6 decades. And let me try to break it down why we don't have any causal association between PDA and outcomes, nor have we seen any benefit of PDA treatment in terms of outcomes. So the first problem, sorry, just trying to get this. So the first problem is a high degree of open label treatment in placebo-controlled trials. So Hunscheid et al. Did a systematic review of 32 placebo-controlled trials done so far. So when I say placebo-controlled trial, the intervention arm will have a COX inhibitor versus a placebo. And as you can see there, the median percentage of open label treatment in the placebo arm, which should ideally be 0, was 52%. So 52% babies were given either ibuprofen or indomethacin I don't think so there was any paracetamol in most of the trials, or they needed some surgical ligation. So ranging from as low as 0% to as high as 75 to 80% in few trials. So that has been the first problem in most of the trials done till date. The second problem is substantial clinical and echocardiographic heterogeneity, which Naveen mentioned. Most of the trials, if you look at 41 out of the 68 included trials, so almost 60% of the trials, the gestational age, the mean or median gestational age of included infants was more than 28 weeks. And we all know, I'll come to it thereafter, that babies who are more than 28 weeks are more likely to have spontaneous closure of their ductus from 1 week to 2 weeks. So we really don't have to subject these babies to drugs which might have low efficacy and might have a poor side effect profile. Second point is there's lack of clarity with regards to identifying the at-risk population. Who are at risk? Is it really a 25-weeker who is an IUGR baby who will be at more at risk? Or is it the 23-weeker who is 600 grams, who's complicated with neck and has recurrent sepsis? So there is no clarity as to which babies might benefit from closure. Is it the mild shunt volume patients or moderate or severe? And a lot of work needs to be done in that regard. And lastly, there's lack of standardization of definition of hemodynamic significance. Out of the 67 PDA treatment trials, almost 1/4 did not mention how the PDA diagnosis was established, and 10% only use clinical criteria. And the rest, most trials, if you see till date, they will look at only PDA diameter or LAO, left atrium to aortic root ratio, which are very poorly reproducible. They are not reliable amongst all the echo parameters done till date. And lastly, the problem 3 is poor efficacy and suboptimal safety profile of common medications in an at-risk population. So whenever we are, as clinicians, as bedside physicians, whenever we are thinking of PDA treatment, I'll encourage you all to always address the question, what is the benefit of this PDA treatment? Is it truly going to change the trajectory of the outcomes of these patients? And what is the risk of giving this patient a medication? So always have your benefit risk profile assessed before giving it. And there's more and more emerging evidence, especially in the past 2 years. The Sung trial, which was published in JAMA Pediatrics, who had 23 to 30 weeker preterm infants who were assessed between day 6 to day 4, randomized to ibuprofen versus placebo. Open label treatment was 0%. And as you can see, the efficacy in 23 to 26 weeks was as low as 8%, with no differences in clinical outcomes. So again, this highlights that using the traditional dose may not be beneficial, and you might have more side effects of ibuprofen than having a true benefit in babies who are really at the border of viability. We had the big PDA tolerate trial by Dr. Kleiman, and it was a multi-center trial where they compared 2 approaches, early drug treatment, and this was a secondary paper. So this was a multi-center trial of 25-weeker babies between 6 to 14 days age of enrollment. And as you can see in these 202 patients who were enrolled, the success rates, the efficacy rates of early drug treatment was quite low. For Tylenol, it was 27%. Ibuprofen alone was around 43 to 50%, and indomethacin was 62%. But there was no discussion about the adverse effect profile and whether that offsets the efficacy of the commonly used drugs. And lastly, this was a trial which was published by recently in Journal of Perinatology by the Memphis group. And as you can see, we were quite hopeful of acetaminophen being the game changer with having a superior safety profile. Uh, so in small babies, 25 weekers, when they received either Tylenol or indomethacin, the efficacy of Tylenol was just 6%. And the Cochrane review, which I've just finished recently on uh, acetaminophen for PDA treatment, which will be up soon, will also mirror the same, that the efficacy in the small babies of Tylenol with the current dosing regimen is very low. And let's look at the safety profile of NSAIDs for PDA. Intestinal perforation rates for ibuprofen is almost 5% versus 11%, so it's still significant for indomethacin. Neck rates are 7.2% versus 11%. GI bleed rates are almost identical, and oliguria is 3.4% in ibuprofen versus 12.4% in indomethacin. So as you can see, indomethacin has slowly is on the wane, and there is less appetite for its use because of the safety effect profile. Safety profile, high incidence of neck, high incidence of AKI or oliguria, and again, sizable amount of patients develop intestinal perforation, especially in the IUGR population, which we well know of. So what is the solution? And how we can do better research and how we can improve the care of our babies in future. So the solution one for the problem one was we should have placebo control trials with minimal or zero contamination of the placebo arm. And there have been a lot of these trials, some of them which have been published, some of them like the Benedictus and the Baby Oscar trial in UK. Benedictus is in Europe, which are still undergoing, and this might give us answers as with regards to, is early targeted treatment helpful or of benefit in reduction for key clinical outcomes. So Cote d'Ivoire is a neonatologist in Newcastle, and his group recently finished a trial, a single center trial in 72 babies, so really small babies, less than 28 weeks, early targeted treatment, ibuprofen versus placebo. They were looking at mortality, was composite outcome of mortality and BPD, and no open label treatment was permitted. Apart from early PDA closure, there were no other differences, but it was a small trial of 72 babies. Elkofage from Dublin also did a similar study in small babies with zero permission for open label treatment. And they looked at PDA severity score, which will come to it shortly. And again, there were no differences, but again, small trials, so not enough power to detect differences. Triocapi was a big multi-center trial done in Europe, primary center being France, small babies, but again, 63% of the placebo arm had open label treatment. What they did see, and what even the DETECT trial have shown us, that early targeted treatment, you might have reduction in pulmonary hemorrhage, reduction in severe IVH. And lastly, the big trial, Benedictus, is 564 babies. And this will definitely give us some clue in addition to Baby Oscar. And we could meta-analyze all these trials to see, does early targeted placebo-controlled trials of ibuprofen versus placebo confer any benefit with reduction in clinical outcomes. The next solution for our second problem is we have to identify at-risk infants with consistent definition of hemodynamic significance. I'll encourage all the attendees to attend this, to read this pilot trial by Afif from Dublin in Ireland. So he enrolled 60 neonates. Mean gestation was 26.3 weeks. Intervention was IV ibuprofen of 1055, control arm was placebo, outcome was a composite of BPDA or death, and the way they randomized to intervention versus placebo was the PDA severity score more than or equal to 5 at 36 to 48 hours. So what is this severity score? And they had done they had validated this score in a previous prospective observational study. It's a composite score of 5 variables: gestation at birth. We all know smaller babies are born more preterm, especially the ones less than 26 weeks, are more at risk for developing hemodynamically significant PDA. PDA diameter, which is the most commonly used echo measure. So that was what the second variable. PDA Vmax, so velocity, the maximum velocity of PDA, left ventricular output, which normal range is 150 to 300. And so that was the fourth variable. And lastly, to ascertain the diastolic function of left ventricle and left ventricular A prime, and they devised this PDA severity score, which is listed here. So when they validated this score, PDA severity score more than or equal to 5 had a higher risk of CLD or death. The area under the curve was quite robust. It was 0.92. And as you can see, it was quite sensitive with a good positive predictive value. The second scoring system is by one of my mentors, Patrick McNamara, who is the chief in Iowa right now. This was the scoring system, quite a busy slide, but it's essentially taking into account your clinical as well as your echo parameters. And the clinical variables range from asymptomatic to severe oxygenation difficulty, or pulmonary hemorrhage, or neck or acute renal failure. And your echo parameters range from a closed ductus to a restrictive ductus to a moderate sized ductus versus an unrestricted large ductus with a large shunt volume. And essentially, if you look at the echo parameters, they looked at diameter, the flow pattern, the transductal flow pattern, looking at Vmax, looking at left heart volume loading measure, LAO ratios, left heart pressure loading measures, which I'll come, if you want to more explanation, I can explain it. And lastly, one of the key parameters is reversal of flow in your superior mesenteric artery, middle cerebral artery, abdominal aorta, or renal artery. So what's the solution 3? What are the newer therapies or newer drugs which may have higher efficacy, which may have better safety, and this overall a good efficacy safety profile? And I'll come to each of these 4 strategies. First is high dose ibuprofen. Second is combination treatment of ibuprofen and acetaminophen. Third is prolonged therapy of acetaminophen. And lastly, transcatheter device closure is picking up especially in North America and Europe. So ibuprofen, what dose? Traditionally, we have been using 10-5-5, and Hurt all the way, almost 14 years back, he had done this PK/PD study to see what should be the ideal ibuprofen dosing scheme. And what he did notice that the metabolism increases of ibuprofen after 72 hours, and because of increased CYP enzymes after birth, and thereafter your clearance also increases because your GFR picks up, your urine output picks up. So higher hepatic metabolism, higher clearance. So you may need a higher dose. So this paper did look at generating area under concentration curves at multiple time points, and they came up with this modified dosing regimen. For 0 to 3 days, it's 10-5-5. So in the first 3 days, if you're giving early treatment or early targeted treatment, it's 10-5-5. From 4 to 5, it's 14-7-7, and 6 to 8 is 18-9-9. So what has translated into clinical practice is 10-5-5 is standard dose and high dose is 20-10-10. So coming to the question, which medication is the GOAT, like Nadal or Federer, greatest of all times? And extensive work done by my colleague Shovik from Halifax. He looked at 68 RCTs enrolling almost 5,000 infants, compared all the permutation combinations of treatment. Overall PDA closure rate was 67%. The primary outcome was looking at hemodynamically significant PDA closure, and secondary outcome was looking at morbidities. Network meta-analysis with all studies included, when you looked at PDA closure and PDA ligation, high dose oral ibuprofen came number one, and high dose IV ibuprofen was for those outcomes was next in line, followed by acetaminophen and thereafter standard dose ibuprofen. Even when they looked at high quality studies, removing the studies which were poor quality, again, their conclusion did not change between high dose ibuprofen still coming trumps on their subgroup analysis. But I always say the devil is in the details, and you always have to tease out when and read articles in depth, because if you look at the data which is available for high dose ibuprofen, there are just 3 RCTs in total. So out of the 4,500 babies, when we attributed that this would be the number one pharmacotherapeutic drug, there were only one data available from 157 neonates. And most of these babies, 2 out of these 3 RCTs were done in babies who were 30 weekers and old babies. So we recently, it's under publication, one of my fellows did this project of efficacy and safety of high versus standard dose ibuprofen for PDA treatment in preterm infants. And as you can see, we clubbed RCT data. So there were 3 RCTs and 3 observational studies. And so RCT data did support that you might have higher ductal closure after first course in comparison to observational data. And the overall there, it was just crossing the point of no difference, which was 1. So the major benefit of high dose ibuprofen stems from reduction in PDA ligation, which was again driven by observational study data. But what we have seen and what we have discussed in the manuscript is there is a cumulative increase in efficacy with high dose ibuprofen. And we saw that after the second course of high dose ibuprofen, you had more efficacy, and that could be possibly the reason why you had lower rates of PDA ligation. The next in line, which you might have a lot of data coming up in the next few years, is combination therapy. As Naveen mentioned, COX inhibitors are the common NSAIDs which have been traditionally been used, ibuprofen and indomethacin, and acetaminophen works on the POX peroxidase element of the prostaglandin H2 synthase complex. And so when the first trial was done, they said, why not? Because they have different mechanisms of action, why can't we combine these 2 drugs and let's see the response? We recently, this Cochrane 2022 for acetaminophen for PDA treatment is going to come soon. And what we did see, there were 2 RCTs comparing combination treatment versus ibuprofen plus placebo. And there was no difference in treatment in a failure of ductal closure after 1 course, but after multiple courses, after 2 courses, there was benefit in the acetaminophen plus ibuprofen group. We recently have got a grant in Toronto to conduct a multi-center trial for combination therapy, which we are going to conduct in 400 babies. So we may have more data emerging in the next 3 to 5 years that is this treatment here to stay. And lastly, prolonged therapy of acetaminophen. Currently, we are using 15 mg per kg per dose Q6 for 3 days for early treatment. But for later treatment, beyond 7 days of life, we are using 5 to 7 days of acetaminophen with the intention that longer therapy will have a higher cumulative dose and possibly better efficacy. So is there any evidence for prolonged therapy? Yes, from Australia, when Dr. Clarkow looked at late therapy of Tylenol for 5 days compared to placebo, as you can see, purely ductal closure rates were 15%, but when the hemodynamically significant PDA became non-hemodynamically significant, it was 63%. So there is some role of prolonged therapy of acetaminophen. A study which was published right at the beginning of the acetaminophen wave by the group at Surya Hospital in Mumbai did show 100% closure rates with 7-day course of PA paracetamol compared to 94%, 95% efficacy rate with IV indomethacin. So somehow there is a signal here that maybe prolonged therapy of acetaminophen may result in better efficacy. It's very safe. We have used paracetamol in 300 babies in Toronto so far. We have not seen a single case of hepatotoxicity so far, possibly attributed to immature hepatic metabolism, low CYP enzymes, and the efficacy rate has ranged from 50% to 60%, more so with prolonged therapies. So there are more and more units which are using paracetamol as a last-ditch attempt after 2 courses of NSAIDs to avoid a definitive closure by transcatheter or ligation. And lastly, there has been a big wave of using percutaneous closure of PDA by these devices. This is the Piccolo device, which is recently approved by FDA, and it's manufactured by Abbott, and it's a safer alternative to ligation. Essentially, ligation can have cosmetically disfiguring deformities. You could have a winged scapula, you will have a thoracotomy scar, you could nick the recurrent laryngeal nerve and call vocal cord paresis. At times, you can have chylothorax, hemothorax. So a lot of problems with surgical ligation, both in the short term and long term. So we did look at what is the efficacy, the technical success rate of percutaneous closure of PDA in infants, in smaller babies, less than 1500 grams, and is there any benefit of percutaneous closure versus surgical ligation in preterm infants? So our manuscript was published in 2021 when we looked at all the data from all over the globe. Our PICO was in infants less than 1500 grams with hemodynamically significant PDA. Does device placement, once it's done, what's the technical success rate? What are the rate of major adverse events? And what's the procedural related mortality? So we looked at studies all the way till April 2020. Our primary outcome was technical success. And as you can see, there were 28 studies, including 373 infants who were VLBW. The overall success rate was 96%, ranging from 93 to 98%. The common reasons for failure, in 3 cases, they had nicked the pericardium, causing cardiac perforation, leading to death. 3 cases where the PDA was very wide, And we have seen if you have a PDA beyond 3.6 or 3.8 millimeter, you don't have a good size device or a wide enough device to fit in. And so these patients did go for ligation. In one case, there was IVC dissection because you essentially enter from right femoral vein through the IVC, you enter your RA, tricuspid valve, RV, and then you go through your PA and then release the device. One case of coarctation of aorta, which we have also seen at sick kids, where the device has migrated into the aorta and caused coarctation. One case of tamponade and one case of LPS stenosis, left pulmonary artery needing retrieval. So what babies formed those 373 babies? They were roughly around a kilo. The mean age of closure was roughly around the 1 month mark, and the common device used was the Piccolo device. The overall procedural mortality was 2%, and there is a steep learning curve for any center to implement this. The major adverse events rate was 8%, and the minor adverse event rate was 19%. So this is the graphical representation of when should you do this procedure to have the least rate of failure. And when we looked at multiple logistic regression model, the later you do this procedure, higher is the success rate. If you do this procedure in the first 2 to 3 weeks, there is high likelihood of technical failure and not achieving the desired result. Our second meta-analysis, we looked at, is there any benefit of percutaneous closure versus surgical ligation when we look at the data? And there's no difference between the technical success rates between the two. Major adverse events rates were the same, but essentially in percutaneous closure, you are not handling, there is no scar, it's not a thoracotomy, you're not handling the lung, you're not subjecting your child to GA for prolonged duration. And so the need for post-procedure inotropes or incidence of post-ligation cardiac syndrome was significantly less in the transcatheter group, which was reassuring to see. And lastly, babies who were in the TCPC group, they returned to baseline respiratory severity. So they got to lower mean airway pressures, lower FiO2, were extubated earlier in the transcatheter group. Lastly, the primer on conservative management was, is this really a dangerous trend, or is this an emerging safe and effective therapy? And as you can see, this is the Canadian database which we have. When we look from 2006 to 2012, in 2006, we were around 18% conservative, and slowly we are inching towards 40%. And simultaneously, pharmacologic or ligation rates have declined over the years. And similar data has been presented from US too, that across gestational ages, you have an increase in conservative management of PDA. And essentially, this boils down from the first study of spontaneous closure of PDA, which was studied in 2 units, one in Dublin, one in Prague in Czechoslovakia, 280 preterm infants, out of which 85% had spontaneous closure rate and 93% by the time at the end of 1 year. But the key message from this slide is, if you look at babies from 1,000 to 1,500 grams, the median time to closure is 8 to 9 days. And babies who are about 28 weeks, again, it's 8 to 9 days. So it's okay to observe these patients, monitor them for spontaneous closure rather than subject them to hazardous medications with possible poor efficacy or worse adverse effect profile. Babies who are less than 1,000 grams, especially between 750 to 1,000 grams, the median time is 3 weeks, but babies who are less than 750 grams, they take a long time. And so is it really ethical to subject these babies to prolonged uh, shunt, high volume, moderate to high volume shunt due to a PDA, which may be associated with problems such as pulmonary overcirculation, worsening lung disease, and possible neck. So I always say conservative approach is the Netflix of PDA management. It's very trendy, it sounds fancy, and there has been data which is emerging. And these are all these studies which have been done so far, ranging from relatively mature babies to smaller babies. And some centers have done no active intervention. When you say conservative means no treatment, but some centers, especially from Taiwan and some European centers, when you say conservative management, it's increase in your PEEP, which will increase your PVR, so limit the shunt, you decrease your eye time, you reduce your fluids, and so these, and especially in Taiwan, they use PRN diuretics. Uh, and as you can see, spontaneous closure rates range from 65% to 100%. One of my fellows recently submitted this for publication, and we looked at conservative versus active treatment and looked at all the outcomes. So there's no difference in mortality, no difference in BPD. So it seems safe, but we need to define in what population. Coming back to the Sembarova study, what we have adopted in Toronto and some key centers in US is that if the baby is above 1,000 grams and about 28 weeks, we'll closely monitor these patients for spontaneous closure. If 26 to 28 weeks, we assess case by case basis and only subject them to assessment or treatment if the shunt volume is high. Less than 26 weeks or less than 750 grams, we are aggressive in doing early targeted screening, and if it's significant, giving early targeted treatment, because this is the group where babies could be at risk for multiple morbidities. In short term, it could be severe IVH, pulmonary hemorrhage. In long term, it could be BPD, neck, or other common morbidities. So what should be a definitive trial look like? And there have been, so design wise, it has to be randomized, parallel design, blinded, and we are creating a central repository in Toronto, so that all the echoes could come to us and we could assess them without having outcome like an assessor bias. So that is the ideal study design. We need to do more trials in babies who are less than or equal to 28 weeks, especially in the less than 26 weeks. We need to stratify babies so that we have equal representation from 22 to 24 weeks and 24 to 26 and thereafter. We need to have very judicious exclusion criteria. If you have a bidirectional shunt, these babies need to be excluded. If you have ventricular dysfunction, PDA might be helpful. So these babies should be excluded from these trials. We need to have consensus amongst our group for standardized echo criteria and definition for hemodynamic significance. I believe so the PDA severity score by Afif Kufash is the way to go. He has done an observational study, validated the score, done a pilot trial, and is now doing a multi-center trial. And it does take into account gestational age, echo parameters, and diastolic function. Lastly, intervention-wise, we need to answer these 4 key questions. Does actively closing a PDA improve your patient outcomes without inducing treatment-related adverse effects? That's the first question. Can selective early closure of large volume PDA shunt by conservatively managing moderate or low volume shunt improve patient outcomes without unnecessary exposing infants to adverse effects of PDA treatment. Third question is, what is the safest and most effective modality? Safe should be first rather than effective modality, because we don't the pendulum should swing the other way. Safety comes first in addition to efficacy to close a PDA. And last, does the choice of modality depend on the timing of treatment, early treatment versus late treatment? So what are the take-home points of my talk today is there are a lot of limitations of RCT evidence to date. There is high degree of open label treatment in the placebo arm. Your inclusion criteria is not validated to identify high risk infants. And we have a big prospective study, RESET PDA study in Canada, which is going to identify which preterm infants with which echo criteria and correlate those with adverse clinical outcomes. Simplified evaluation has been the bane of PDA research so far. Poor efficacy and poor safety profile of available pharmacotherapy, especially in at-risk infants. So these are the major limitations of RCT evidence till date. What are the possible solutions that might provide answers? We need to have more placebo-controlled trials with no contamination. We need to have judicious selection of at-risk infants. We need to have consistent definition of hemodynamic significance and standardized echo criteria. And newer therapies on the horizon, which may take off in the next few years, is high-dose ibuprofen, especially in the small babies. Ibuprofen plus paracetamol. We have a big multi-center trial in Canada rolling out soon. Longer duration of IV or PO paracetamol. My PK/PD work will inform what is the right dose and what's the right duration to ensure efficacy and safety. And lastly, if you have a baby who has a large duct, even after multiple courses of pharmacotherapy, maybe it would be a good idea to have definitive closure earlier than later with transcatheter closure rather than surgical ligation. I would like to thank all my mentors from India to Australia to Patrick and the whole group, hemodynamic group in Toronto and Iowa, and my family. Thank you. And I would like to invite questions from the group.
Thank you, Bonny, for such a wonderful talk. And you have made this so much difficult topic looks very simple. But yes, as you rightly said, that there are many questions which we need to answer. But till the time the questions are being answered, it will take years, and practically people have to do something. So there are few questions. So first question is from Dr. Shekhar, that in resource limited settings where echo is unavailable and clinical PDA is suspected, what should be the treatment strategy?
Right. So in resource limited settings, we need to look, there are some bedside clues which will tell you this PDA is significant. Always look at your blood pressure. If you have a wide pulse pressure or if you have low diastolic pressures. So diastolic hypotension is quite a consistent finding in the first week of life. And if you have that in presence of a baby having a significant murmur, and if you have end organ compromise, so if the patient is stuck on respiratory support, or if there's escalation of respiratory support, so a stable prem has more spells, needs to be intubated, has a pulmonary bleed, or has worsening lung disease, these are the patients who will need treatment. And if there are no contraindications for treatment, use Tylenol. I say Tylenol all the time, it's paracetamol, 15 mg per kg per dose, Q6. For early treatment is 3 days. After 7 days, it's 5 to 7 days. If there are contraindications, use paracetamol. But if there are no contraindications, use ibuprofen. In the first week, we use 10-5-5. After a week, we use 20-10-10 of dose, and monitor your renal function. Get a baseline panel of your labs If you're giving Tylenol, we do monitor AST, ALT. And if you're giving ibuprofen, we do monitor platelets, creat, urine output, and bilirubin.
So thank you, Bonnie. Just a point to add here that in India, we don't have the IV ibuprofen. So the oral ibuprofen is the only, and sometimes the baby abdominal distension or neck is there, and then it's slightly difficult to use.
And that's the reason. Paracetamol, you could always start with it, reassess after 3 days, see if you still have no significant improvement, stretch it to 5 to 7 days. There is no harm. I think my data on 300, 350 babies with paracetamol is going to be published soon, and there's absolutely no bad side effects with paracetamol.
Thank you. Thank you. Pragati is asking, when we don't have the bedside echo facility and clinical suspicion, so this has been answered. The second is, when and in whom to start prophylactic treatment?
Prophylaxis treatment is, we even in Toronto, in one of the centers, we do prophylactic treatment. We do prophylactic indomethacin. There is most evidence for endo. So based on the TIP trial, we do 0.1, 0.1, 0.1, 3 doses, 24 hours apart. So you have to determine which babies are at highest risk of developing PDA issues, right? Severe IVH and pulmonary hemorrhage. The benefit of prophylactic treatment as seen in TIP trial was reduction in severe IVH. And once you look at the meta-analysis, reduction in severe IVH and pulmonary hemorrhage. So what we do is less than 1,000 grams in one center, we start prophylactic endo and give it, and thereafter see if the patient does have any benefit of it or not.
Yeah. So thank you, Bonnie.
It's a balance of resources also. Like if you don't have echo resources, but I personally, we should not give prophylactic endo to severe IUGR patients. So if you have a patient who is 28 weeker, but 700 grams, these patients will have more gut ischemia. Giving endo is setting this patient for problems.
Yeah. So I think very rightly said. So Pragati, if you have the facility of echo, I don't think so that prophylactic treatment in nowadays should be done. And if you don't have the facility of echo, then maybe less than 26 weeks is the some population where the PDA, the significant, the HSPDA will be more, so that can be done. So on prophylactic treatment, I always remember a statement by Dr. Nick Evans in one of his review articles. He said that because in PDA we don't have so much of, I mean, there's so much controversy is there. So if you are an evidence purist, either give prophylactic treatment or don't treat at all, because a lot of data is for prophylactic treatment, as you rightly said.
Yeah, a lot of the earlier data is from.
A lot of early data. So Pragati is asking again, how does increasing PEEP and decreasing the TI helps in closure of the ductus, closure of PDA?
So it's the Poiseuille's law, right? Like PDA is a channel, and essentially the shunt volume is dependent on what is your SVR and what is your PVR. How can you increase your PVR? You can increase your PVR by increasing PEEP. You can increase your PVR by having higher CO2 targets. You can increase, and the other elements of Poiseuille's law is viscosity, which I think there was a trial in PGI where they looked at platelet transfusions. It did not have any benefit, but there is more and more role that we should have higher hemoglobin to have more viscosity. So those are essentially it is to mitigate the shunt by increasing your PVR or pulmonary vascular resistance. And that is the physiologic rationale for it.
Yeah, thank you. Ibuprofen, if at all required for medical closure, then should we uniformly use the high dose?
If the patient is less than 7 days, 10-5 is good. Beyond 7 days, there is higher metabolism, higher clearance. Always before using 20-10-10, ensure your renal function is fine and your gut perfusion is okay, like there is no feeding intolerance, because 20-10-10 is a high dose. And so far, the safety profile looks okay, but we don't have robust data. So beyond 7 days, the long answer short, you
Yeah.
can use 2010.
Yeah. So Bonnie, the next question is from Rashmi. Do you recommend fluid restriction in case of HSPDA?
Yes and no. Our center we don't, uh, but there have been centers, especially from Taiwan and few of the conservative management centers who are quite aggressive on fluid resuscitation, fluid restriction. So I would not restrict below 130 to 140 uh, because you do not want to. There is a balance between nutrition and restriction, and preterm infants do need nutrition to grow. And so you have to strike a balance between, if you truly want to restrict fluids, uh, I would go to 140, 140 at the most.
In
But
fact, there is some
none of our,
recent data that if we restrict fluid, it is more harmful rather than doing good.
right. So there are, again, it's a pendulum swing, which fluid restriction can lead to more BPD. And there is now another paper from not our group, but from Toronto. So that's the reason none of our centers in Toronto we do it, and it's not evidence based as such, but it's one of the strategies which is used.
Yeah. Yeah. Deepthi is asking, we can increase PEEP till, so what is the upper limit of PEEP as per she's asking?
It's based on your lung disease, so underlying lung disease. So 6 to 8, I would say, we can start and then slowly increase and see. There is no magic number till what we can go, and yeah, I would say till 8.
Yeah. Jyoti is asking role of furosemide. I think fluid restriction you have already covered it, and furosemide in is it helpful
So
in?
I was right. So furosemide actually physiologically can cause the patency of ductus, uh, and it increases your PGE2 levels. It seems counterintuitive, but most of the conservative studies have used furosemide, some of them, as an ancillary strategy. Uh, I wouldn't use both because then you are really drying the patient. Is either or. But conservative strategy in Toronto, what we do essentially is keep the patient's hemoglobin on a robust level, keep a high PEEP, keep high CO2 targets as long as your pH is well. We do not want the patient to saturate beyond 95%, so have tight SATs targets because oxygen is the powerful vasodilator. So we do not do fluid restriction in furosemide. I was presenting data with some centers across the world too.
Yeah, thank you. Uh, so question from Hemant, large ductus with mildly raised pulmonary hypertension with minimal or no respiratory support, to close it or not? I think you answered it.
So for me, symptomatology comes first. If you have no respiratory support or a very stable baby on high flow or low PEEP, I would just monitor this patient and see what happens, but I would not close the ductus. And again, in face of pulmonary hypertension, you do not, ductus is your friend, so you do not want to close a ductus when you have a right to left shunt.
How many doses of paracetamol or ibuprofen should be given before considering surgical management? How many courses should be there? Okay.
So there's no robust evidence to it. We started off with two courses, and now we stretch it up till 3. But there is a healthy balance. So you do not want the duct to stay for months together. So you can maximum finish 3 courses by day 21 or day 27, taking into account by second or third week. And thereafter, if you still have a rip roaring ductus and if your patient is stuck on the ventilator or has necrotizing enterocolitis or needs inotropes, then I'll go ahead with surgical management. We do use paracetamol as a last ditch attempt to see if we can avoid doing ligation or percutaneous closure.
Yeah. So Manoj is asking interesting question, the role of caffeine in PDA with the CAP trial, I think.
The CAP trial did show reduction, but uh,
I think no,
these are all
no.
confounders. There is no real physiologic, mechanistic role of caffeine in PDA.
Hmm. So Amit is asking, does antenatal glucocorticoids help in decreasing PDA incidence and can act as a preventive measure? Yes.
So the antenatal glucocorticoid studies, if you see the Cochrane by Roberts, it does show that the PDA incidence is less, but we do antenatal glucocorticoids regardless we give to mothers if there is risk for preterm delivery. So, and we have to follow between 24 to 34 weeks. I would not subject mothers beyond that to receive it because PDA is not a problem thereafter, beyond 28 weeks.
Rashmi is asking, how do you manage PDA in baby with PPHN? I think you answered. So two conditions where PDA should not be closed is the PPHN, where the duct is a friend, and cyanotic congenital heart disease. So I think majority of units should have a protocol that first echo should be done by the cardiologist to rule out the structural heart disease before we jump onto treating ductus, because sometimes it is, yeah, definitely helpful.
Absolutely. PDA is your friend. The only way to increase your SVR, overcoming PVR is through the PDA. So you have to sometimes you even give prostins to open up a restrictive PDA in very severe cases of PPHN. So don't think if you have a right to left or a bidirectional shunting PDA, leave the PDA alone. Do not treat it medically.
So Hemant has posted a clinical scenario, mild pre-post ductal saturation difference, like pre-ductal around 96, post-ductal around 91, 92. I think again PPHN he's talking of. SpO2 narrow with 25 to 30%, FiO2 flow of 2 to 3 liter per minute. What is flow? Is it PDA raising the pulmonary pressure or pH not letting the duct close? The management in such a case.
So let me explain the physiology. Every baby is born with high, like the babies who are admitted in the NICU, most of them will have some high pulmonary pressures at birth. The pulmonary pressures will slowly decrease. In normal healthy term newborns, there is a precipitous fall in your pulmonary pressures after birth. The fall is less pronounced, especially in elective C-section, late preterms, early terms, patients who are difficult to transition. So when does PDA truly cause PH? After weeks. If you have a PDA, a large PDA, we had one paper from the Memphis group. They said if you have a PDA for beyond 4 weeks, then it will cause pulmonary hypertension. So and definitely beyond 8 weeks. So PDA causing pulmonary hypertension acutely is not physiologically, that's not the scenario. So what you are saying is PDA raising the pulmonary pressure is a very chronic event. It's not an acute event. And pH not letting the duct close, pulmonary pressures will slowly and steadily wean off on its own. You really don't have to do anything. You just have to give good respiratory management, good PEEP, good FiO2 to maintain your target stats, and your PVR will fall down and your patient will improve with time.
Yeah. So Siddharth is asking, didn't the Cochrane review by Bell 2014 show fluid restriction reduced risk of PDA, or did you indicate fluid restriction for treatment? So I think you answered this question.
Yeah. So I think there are so many questions on fluid restriction. That is, if you see the pyramid of PDA, that is the least important intervention. Don't be obsessed with fluid restriction because it's not a magic bullet. It's not a magic drug. It's not going to work wonders. It might just temporize the situation for a bit. So I would encourage everyone that it is one of the bottommost interventions in the whole pyramid of interventions. options for PDA.
I guess the message people should take in this is that excessive fluid should not be given in the presence of hemodynamic significant ductus.
Right.
That will be a right thing to, yeah. Okay, so Rohit is asking dose of PCT and duration of treatment that you have answered in your slides also, 15 mg. Dose of paracetamol and duration of treatment. So I think you answered 7 days and 15 mg per kg Q6.
Yeah.
Rashmi, last question, sir. What's the echo criteria used in your unit to diagnose HSPDA?
Oh, the echo criteria in Toronto is, we have a whole sheet. But essentially, we look at diameter, we look at LAO, we look at the PDA Vmax and whether it's a pulsatile pattern or a growing pattern or a restricted pattern, which is, we look at left ventricular output and we look at the Doppler flows in abdominal aorta, in celiac artery, SMA artery, and middle cerebral artery to see whether it's absent, reversed. So these are the key things. We look at a lot of other things, EA ratios, IVRT, pulmonary vein Dopplers, but all those are research based.
I just have one question. When is the time you do the first echo and how frequently do you monitor babies who are less than 28 weeks?
Good question. So babies less than 26 weeks, we get the first echo within the first 24-48 hours. The reason being your peak incidence of IVH and your peak incidence of pulmonary hemorrhage is in the first 3 days, right? So if you have a big ductus, in that time frame, if you institute treatment, maybe you can mitigate or reduce the incidence of these morbidities. So for example, if you have a 25-weeker, we will do our echo at 24 hours life. If it's hemodynamically significant, we will start treatment. We'll finish treatment after 3 days, then repeat an echo after finishing to document closure or hemodynamic insignificance. If not, we'll again give a second course. If it's still significant, repeat another after 6 days. So by end of a week, if the patient does have a hemodynamically significant PDA, more or less we will have some degree of either closure or hemodynamic insignificance if the patient has responded to the treatment. Between 26 to 28 weeks, we screen depending on the symptoms, which I said, the blood pressures, and we are more keen in if the patient is severe IUGR, these patients are at high risk of developing large PDA, so we'll screen them earlier. Beyond 28 weeks, we do not screen. We only screen if there are clinical concerns.
Thank you.
And if you go to Australia, where I was there for 2 years, they do their first echo at 12 hours in babies who are less than 26 weeks, because they believe that sometimes in really small babies, 20 to 23 weekers, you could have IVH on day of life 1 around the 24-week mark. So they really want to remove the effect of PDA, and they are very aggressive. So even if it's 3 a.m., we'll get an echo, start treatment. And that could be the reason. If you look at ANZNN data and the North American data, and the Australia, New Zealand have very low rates of PDA ligations. They have very low rates of neck. Even Japan has low rates of some of these morbidities.
Is there more query to this? Is there a genetic factor which determines closure of the ductus? Because compared to the West, I think in whatever many centers I have worked, I think the incidence of PDA is not as much as we read in the text and papers in India.
No, so you're right. It's Akash asking. Okay. So when I moved from India to abroad, PDA is not a problem in India in a big way. And most of our babies do respond beautifully to treatment. The Western babies are very fragile. they have severe RDS. They have severe comorbidities. Again, neck, we don't see that much in India, but in West, it's a huge pandemic. BPD, PH is a pandemic, BPD is a pandemic, which all of that we don't see that much in India. Now, to turn the argument on its head, maybe we are not really doing the 22, 23, 24 weekers that much. That could be one argument. We are the Barker's hypothesis. Most of the mothers, they have the inflammatory drive, and our babies are really robust. So we don't have really severe RDS. Also, that common in India. We have a higher degree of IUGR population in India, which they have a cortisol surge and they are relatively robust. So I think those are all the reasons. So yes, in long answer short, genetics does play a role. And that could be the reason why the Western population or the Caucasian population has a higher incidence of all these morbidities.
Yeah.
And
So
again, if you look at the PDA paracetamol trials, we had excellent results in the trial done in Bombay, like in Surya Hospital or in other centers. But we are struggling with the same dose, better formulation, but with poor efficacy in the Western countries. So extrapolating what you see in the West directly vis-a-vis to our population, to some extent is helpful, but not for complete extrapolation.
Thank you.
So thank you, Bonny. Thank you. It has been wonderful, and it was exhaustive for you. So
I'm on job. I'm working, so I'm just waiting now.
We could see the tag in your neck. So yeah. So thank you very much. Thank you.
Thank you so much for that excellent lecture. I loved it. It was just like a journey, and you made it so simple.
Yeah.
Thank you so much for your time.
I would encourage everyone to read. I can send it to Akash some key articles. There are some excellent review articles, and then it clears your mind and tells you what to do when, and like at least.
I don't think they will be saying more than what you have already said, and the way you have clarified it. It was mesmerizing and with an excellent moderation. Thank you so much to both our speaker and moderator, and have a good day and a good night to all others who are still here in India. Thank you so much. It was a pleasure having you. Thank you.
Thank you, Naveen, and thank you everyone for patient hearing.
Thank you.
Thank you, Akash. Thank you, Bonny. Bye.
Thank you all.